It worked.
No.
Okay. I would like write something and then the sentence would end and like that would start like a new thing. We'll try it off sheet. I'm just so ready to like genetics.
Erica, you got onto ATI fine. Thank you, colleagues, for helping her. We just could not connect. We tried. Seriously, we tried. Like, do you like work all day?
I work and I go back to practice. And before that, I have class. Like,
So your day is just kind of near.
yeah.
Okay, so. Yeah, you're supposed to take the quiz after you finish the case study. That is not recorded for me. Instead, in fact, I put a quiz on there that you should be able to see. If you can't access it, maybe I'm supposed to give you the password, T-test or something. Let's see.
Hi, Dr. B.
Hey, Brooke, can you hear me?
Yep.
You're muted, darling. I can't hear you.
I don't think I'm muted. It doesn't say I'm muted. Let's see.
Oh, there, now I can hear you.
Okay.
You're coming through the house, that's why.
Hey.
I had the house turned down, so. Brooke, how do you feel?
I feel better than I did before. So I got in this big COVID mess thing. I don't know how to describe it. Anyways, but I kind of thought I just had like allergies, you know? So I just played it off as I literally thought I had like mild allergies. I just had like a headache, took Tylenol, it went away. And then my friend tested positive for COVID. And so, but I haven't gotten a COVID test. I didn't get over the whole health today. And the at-home ones are so expensive. So, but I am just
Yeah.
going to assume that I had it. But since my symptoms started 5 days ago,
Yeah.
whole health told me that I'm good to go without a mask or with a mask, but I can go back out and stop like isolating.
Okay.
So, yeah.
Okay. Well, this is fine.
Yeah.
Wednesday we'll have some commuters who might not be able to come in because of the weather.
Okay.
Well, I'll Zoom again on Wednesday. So
Okay. I'll be back. I'll be back then. So.
okay. So does this thing work if I go over here? Can you still hear me?
Yep.
Okay, so it seems to be working. Okay. Very good. Let's go ahead and get started. Let's have a word of prayer, then let's begin. Father, thank you for everyone here. Thank you for this class. We pray, Lord, that through your Son, we can offer a sacrifice of praise to you, the lips of those who profess your name, that we would not forget to do good and to share with others, for that is an acceptable sacrifice to you. In Jesus' name, amen. Okay, let's have a little bit of review. Oh, so many targets, so little time. Clara, what's a half-life? What is a drug half-life? No, you're close. You're mixing your metaphors. There you go. The time it takes for the concentration of the drug to decrease by half. There you go. Very good. Typically, half-lives don't vary as the drug concentration decreases. The half-life stays the same, with some exceptions. There are some drugs that are cleared according to the blood flow of the drug through the liver, because they're cleared by the liver, so it's a flow capacity system. Phenytoin is a good example. Theophylline and heparin are cleared in ways that are not concentration dependent, so their half-lives will change according to concentration. And since heparin's a drug you guys will use a lot, that's one to keep in mind. Maddie, what is clearance? Think of the term clearance. Think of it in terms of a drug. So it's the rate at which, yeah, the rate at which the drug is cleared or eliminated from the body. Can you think of what the units might be for clearance? It's per unit time, correct. So it would be micrograms per unit time, milligrams per unit time, something like that, maybe. So it'll be quantity per unit time. That make sense? Okay, good. Caitlin. Hi, how you doing tonight? Good. Caitlin, which is absorbed faster by the stomach, a weak acid or a weak base? Don't know. Natalie, can you help her out? No. Why not? Right, good. What does it take for it to be absorbed? To cross membranes, it has to be on that an acid or is that a base? Acid. Which one of those moieties gets absorbed? The charged one or the uncharged one? Good, good. Now, work with me here. When are you likely to have more of this than to have more of this? At low pH or at high pH? Yeah, yeah. Where in the body do you have low pH? Stomach. So which is going to be better absorbed in the stomach? A weak acid. Do you see how that works? As I tell my biochemistry students, do the chemistry first, then answer the question. I'll bet you, Natalie, Caitlin, if you'd have drawn it out like this, the answer would have stared you right in the face. I'll bet you. Rebecca, how are you doing tonight? Better than I deserve. Rebecca, which is secreted into breast milk more effectively, a weak acid or a weak base? Now, I'll qualify that. Breast milk is slightly acidic compared to serum. No. Milk is slightly acidic. Ever so slightly acidic, about 6.8 of base. Bases will tend to be more easily secreted in breast milk than acid. Drugs that are acid are very poorly secreted into milk. Jessica, which is going to have wider distribution through the body of a young person? A water-soluble drug or a fat-soluble drug? Blood. Is blood water-based or is it fat-based? Sorry? Yeah, I know it's late. Do you need some of this? Got your energy drink? Okay, you don't need any epinephrine. You seen this before? This is a standing joke with my class. If they fall asleep, they get epinephrine. So water. So in a young person who tends to have a lot of lean weight, the water-based drug will show, complete the sentence. Yeah. So the water-based drug will show better distribution. Now, 3, if it's an older person, you have less lean mass now for an older person. Say someone my age, say that old. Which is going to have better distribution, water-based or fat-based? Water-soluble or fat-soluble? Fat-soluble, fat-soluble. Now, it's an important thing to think about when you work with an aged population. You need to worry about drugs that are fat-soluble because the patient may start to depot the drug in fat stores. Okay. All right, Emily. You're in the ED. Patient comes in with track marks all over their arms, and they're very agitated. And their friends say, yeah, he tends to use amphetamines. Amphetamines are a base. If you want to get that amphetamine out of him faster, what do you need to do to the urine? to get it out of him faster? A little bit of a complicated question, huh? Probably unfair. I played a trick on you. I'm sorry. I'm terrible. Okay. Don't hate me, please. All right. Okay, Emily, think through this with me, okay? If the base goes into the urine and the urine is not very acidic, it can be secreted back into the bloodstream. So it can hit the urine, but then go back into the bloodstream. If you make the urine acidic, it gets charged now in the urine and it's trapped in the urine. You'll excrete more of it, right? And in fact, that's one of the things you do for amphetamine poisoning is you use ammonium chloride. Because ammonium is so that gets into the urine, it dissociates, and it drops the pH of the urine. Now the amphetamine gets secreted into the urine and it's trapped there. Won't go back. So you get rid of more of it. So that's, in fact, that's a standard treatment for amphetamine poisoning is ammonium chloride. Very soluble salt. You can put it in IV, boom. Pretty soon, they'll be highly hydrated and they'll be getting rid of amphetamine, and pretty soon they'll be, well, they won't be their old self anymore, but at least their blood pressure won't be, 200 over 120 or something like that. Do you see how that works? Okay, that makes sense? Like that's a dirty trick I pulled. I'm sorry, I shouldn't do that. Okay, I won't call on you the rest of the night just as a reward for that. All right, let's go on to the next thing. Bioavailability. So we talked about half-lives. We looked at this graph. Essentially, the half-life is going to be that overlap between the accumulation and the elimination once you turn the infusion off. That point where those two graphs overlap, that right there, that's your half-life, essentially. So bioavailability, that refers to the fraction of unchanged drug that's going to reach the circulation once you administer the drug, and that's administration by any route. The fraction of the drug that reaches the circulation unchanged, that's really important, unchanged. There's a caveat here. There are some drugs, they're activated by enzymes in your body. They're made in a prodrug form. So the active form is the one that gets to the blood. So when we say unchanged, by that we mean active in those cases. So I'm thinking about a drug like the anticoagulant, dabigatran. Dabigatran is an ester. Your body is full of esterases. So ester is readily hydrolyzed. You take dabigatran, by the time it reaches your blood, the ester has been hydrolyzed and the active form of the drug is now in the blood. In that case, it would be the active form of dabigatran reaching the blood. So that's the one caveat I would include with that. So it's the fraction that reaches the blood that's unchanged, parentheses, active. Bioavailability, very important measure. Some drugs are absorbed very effectively. Fluoroquinolone antibiotics, for example, extremely effectively absorbed. Their bioavailability is very high. Some of them, either 100 or really close to 100%. Oh, this is recorded as a percentage. It's a percentage of the amount of drug that gets in the circulation divided by the amount that you gave. That's how you report this. So this will always be a decimal fraction. Now, if you administer a drug intravenously, by definition, the bioavailability of that drug is going to be 100%. By definition, because you're sticking a needle in someone's arm and giving it straight into the blood system. So by definition, intravenous administration, bioavailability is always 1. Once we get to other parenteral forms, intramuscular, subcutaneous, you can see their bioavailability is still very high, albeit typically not 100%. You can see with oral drugs, bioavailability varies wildly. Some drugs are not well absorbed. Other drugs, when they're absorbed, will undergo something we'll talk about a little bit later called the first pass effect. Which we'll get to in just a bit, but oral drugs are very convenient, but their bioavailability can really be all over the board. That's something to keep in mind. Drugs that are given as suppositories rectally, the rectum has lots and lots of blood vessels. So very often you get pretty good absorption. Some drugs, however, because the suppository tends to be encased in wax, the wax usually dissolves very easily, but the absorption of the drug from the skin into the skin capillaries is difficult for some drugs. So in some cases it can be very high, in others it's not very high. So it depends. Inhalation, in most cases, is terrible. Reason being, when you inhale drugs, typically a lot of it ends up on the back of your throat. So inhalation usually is not very good. The exception is with inhaled anesthetics, because the inhaled anesthetics are not given as a mist. They're given as a true gas, so they just go straight down to the lungs. So we'll talk about anesthetics, serofluvane and others like that. They're very good, but a lot of your others not so good because of the fact that they tend to get stuck in the mouth, stuck in the tongue, stuck in the back of the throat, so on and so forth. Transdermal tends to be good, really good. The issue with transdermal is that you have a patch with a vehicle on it. The vehicle gets the drug straight through the patch. The drug has to be soluble in the vehicle. So not many drugs can be delivered transdermally. Those that can are extremely convenient and show very good bioavailability usually. So transdermal is usually pretty good. Now, transdermal, you don't want to use transdermal drugs in babies. Can anybody guess why? How thick is the skin of a baby? Not very thick. So essentially absorption is going to go like that. The kid's going to get too much drug way too fast. So transdermal is out for infants, and some of you might end up doing neonatal work or something like that. And transdermal drugs essentially are Nixay. Natalie?
Why are we able to use those?
Because older patients have more of a fat pad, essentially. That fat pad, essentially, even though the skin gets thinner, also the blood vessels will retreat a little bit. So the movement of the drug from the transdermal pad into the dermis is actually slower because of the marbling of the tissue. That's a really good question, actually. Babies, however, their skin is crawling with vessels and their skin is really thin, so absorption is just lickety split. It's way too high. You're going to poison the kid.
So if somebody who's like overweight, is that make it
Yes,
harder?
yes. Those of you who will do peds, a lot of your topical medicines, you have to determine essentially the percentage body area, and you can only give topical medicines per percentage body area. So you have to measure body area, and you have to make sure that whatever medicine that they're putting on topically only covers a certain body area, or the absorption is going to be just too great and they're going to have too many systemic side effects. But with older people usually, or obese people, absorption can be erratic sometimes. And some obese people do fine with certain patches, others don't. Fentanyl, for example, which gets used a lot as a patch after surgery, obese people may have a big problem with it. The other issue is that the fentanyl can depot in the fat. And so they can all of a sudden get this release of fentanyl from the tissue that can potentially poison them. The problem with fentanyl, and we'll talk about this when we talk about opioids, because fentanyl is pretty potent, you don't use fentanyl on an opioid naive patient usually. they have to have experience with opioids before you use fentanyl usually. Fentanyl can still be used because it's used for breathing tubes. It can still be used for that, but it's usually used at really low concentrations for that. That's not an issue, but post-op, you're usually not going to use fentanyl unless they're not opioid naive. The patient's opioid naive, you don't use fentanyl. You'll poison them. And with patches too, there have been several cases of kids going into trash cans, and we all know how curious kids are. Oh, look, vehicle. Oh, gee, that feels really good. Oh, gee, and kids have died because they play with the patch on the throat. This patch, you're supposed to take it, fold it, flush it. That's not just with fentanyl, but any patch. Don't throw it in the trash. Flush it. Flush it. Always. That's a big teaching part with patches you'll have to do with patients. Do not throw it in the trash. Don't let it go to landfill. No, 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 1,000 times no. So this is just kind of the bottom line from all that. Your different routes of administration will show very distinct bioavailabilities. Some will avoid this first pass effect, others will not. First pass effect tends to affect mainly oral drugs. So bioavailability will depend first and foremost on the extent of absorption. Then it depends on how much of the drug is eliminated when it passes through the liver for the first time. Some drugs will induce the enzymes in the liver that metabolize them. Others will just be metabolized very quickly by the liver. And this is the essence of the first pass effect. Think of where blood from the GI tract drains to. To where does it drain? Erica, where does it drain? The blood from the GI tract drains to where? Where's the first organ that goes after the blood goes from the GI tract? It goes to the Haley? No, that's not right at all. Liver, liver, liver. It drains straight into the portal system. So oral drugs, they get absorbed, they go straight to the liver. Some drugs, when you take them orally, they get degraded extensively by the liver before they ever get to systemic circulation. That's the essence of the first pass effect. Some drugs show extensive first pass metabolism. The biggest one is morphine. And a lot of your morphine derivatives and morphine like molecules. So a lot of your opiates. That's why a lot of your opiates are prodrugs. The prodrugs, essentially, they get metabolized and they get metabolized into the active form. So codeine, for example, is metabolized by the liver into morphine. And it reaches circulation before it gets degraded. That's why morphine is rarely given orally. There is an oral version of it that's marketed, but it's usually given parenterally because the first pass effect on morphine is extensive. So morphine will not usually get to tissues of very high concentration. There are other drugs that also undergo extensive first pass effect. So the first pass elimination is going to depend upon something called the extraction ratio. And the extraction ratio just very simply is the rate at which the liver clears the drug, rate at which the liver degrades the drug. You divide it essentially by hepatic blood flow, which a good adjusted number for this is about 90 liters per hour. And if your patient has liver failure, if they have liver disease, they're an alcoholic, if they have non-alcoholic fatty liver disease, something like that, that can affect clearance levels and things like that. So the extent and the rate of absorption and the amount of first pass elimination, that's going to determine your bioavailability. And this picture, I think, shows you how first pass effect works. If the oral dose, it goes to the gut, and then from there it goes straight to the liver. Systemic circulation, whereas intravenous doses are going to bypass that. Other ways you bypass that, sublingual doses will do that, will bypass first pass effect. so will suppositories, so will rectal. Some suppositories are inserted into the vagina. Those will also avoid the first pass effect as well. In Great Britain, they used to call them Voltral suppositories. It is it's an NSAID, anti-inflammatory, non-steroidal anti-inflammatory drug. Those came as suppositories. They're not called that in this country. Now, some drugs are converted into metabolites that also themselves have activity. So you have the drug itself and you have its metabolite, both of which are active. Other drugs are converted into metabolites with no activity, and others are converted into metabolites that, if they build up in appreciable concentration, can have pretty serious side effects. So, for example, fluoxetine. Fluoxetine, Prozac, is converted into norfluoxetine, which has activity with fluoxetine, and norfluoxetine is very long-lived. That's why fluoxetine has such a long half-life, because of norfluoxetine. Meperidine, the opioid, is converted into normeperidine, and normeperidine causes severe neurological side effects if it builds up. That's why you should only give meperidine. Demerol is the trade name of that drug. You should only give meperidine short-term, because of the long-term, normeperidine can build up and cause pretty severe neurological side effects. So drugs with these high extraction ratios, they will show a lot of variation in bioavailability between subjects, because the capacity of the liver to metabolize the drug will vary from person to person. It'll vary because of blood flow to the liver. That's something that can be inherited. Also, enzyme levels. And the alleles of enzymes that are in the liver have different activities against certain drugs as well. And that's essentially what that says right there. So the time course of the drug as it's metabolized and excreted versus its concentration, those two items are usually not linear. Let me give you an example. With an antihypertensive called enalapril, this is a so-called ACE inhibitor. This drug has a half-life of 3 hours. So let's say a dude, let's call him Frank. Let's say Frank gets up in the morning and he takes his enalapril, and this inhibits an enzyme called angiotensin converting enzyme. And that's the percent inhibition we get with the drug throughout the day. So at first, it's very high. Then as the drug is metabolized, this drug is taken orally, it will start to fall off. And then by 24 hours, you still have about 33% drug inhibition. That's still significant because the drug inactivates angiotensin converting enzyme irreversibly. So cells need to remake it, essentially. Here's the concentration of the drug after it's been taken. And then as it goes down, even at 0 concentration in the blood, you still have 33% inhibition. By the time Frank wakes up the next day and takes it again, this will then jet back up to here, and this will start all over again. Do you see why it's important that Frank take this drug the same time every day? That's a teaching thing for antihypertensives. Take them the same time every day. Doesn't matter if it's morning, doesn't matter if it's night. You can take them with food, you can take them without food. No se importa, no se manera. Not important, it doesn't matter. Take it the same time every day. Get a routine, keep the routine. Trends that we see here, even 3 hours after the dose, you get your peak plasma concentration of the drug. 7.5 half-lives elapse from the time of the concentration to the end of the dosing interval, which is a day. The EC50 is very low. That's why you can take this drug just once a day even though the half-life is 3 hours. After 24 hours, you still get appreciable angiotensin converting enzyme inhibition. So you can see here from this that the course of the concentration of the drug and its activity, not linear. Not linear. Plasma concentration of the drug after the first 16 hours drops pretty extensively, 16-fold. Yet, ACE inhibition only drops 20%. So don't expect to see a linear relationship between concentration of drug in the body and activity. Those two are usually not linear. Don't just draw a straight line and say, oh, it must be linear. Nope, 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 nope. You did that, you'd be wrong. Some drugs have a lag before they act because they have to build up, or their absorption takes a while. Some drugs have to wait for certain targets to turn over. Some drugs will have cumulative effects. They have to accumulate before they show their effects. Certain cancer drugs are this way. And then aminoglycosides, which have renal toxicity, that renal toxicity is dose dependent. They will show that toxicity only if they build up in the body. That's something to keep in mind when you're looking at concentrations of drugs and how often you dose them. So the term maintenance dose, that refers to the dose required to establish a proper steady state concentration within the body. And for our buddy Frank with enalapril, it was 10 milligrams. Maintenance dose. So here's some examples of a maintenance dose with 3 different drugs administered 3 different ways. And I know some of you don't like graphs, but graphs to me really powerfully illustrate this. So kind of suck it up and just go with me, okay? So here, this is an intravenous infusion. You start the pump, or gravity in some cases. The drug will start to increase in concentration. It gets to a point where the concentration of the drug, rather the rate at which the drug is being introduced into the body and the rate at which it's being metabolized and eliminated from the body are essentially equal. That is an example of a steady state, So your maintenance dose in this case is 28 milligrams per hour. That's your maintenance dose under continuous intravenous infusion. Now, that works if someone say is in an ICU bed. You can't really send them home with a needle in their arm, can you? Nope. So you give them an oral drug. Now, the oral drug, as you can see, will be administered every 24 hours. Notice that you're going to have more troughs and peaks. However, the mean concentration is going to be the same. It's still going to be 10 mg per liter, despite the fact that you have more troughs and peaks, provided they take the drug every 24 hours. That's the maintenance dose if the dosing interval is 24 hours for this oral drug. You can also give a smaller dose of the drug that is smaller. This won't have such big troughs and peaks, and that will look more like this. Notice that this has not nearly as distinct troughs and peaks, but for all 3 of these, notice that their mean concentration is still 10 mg per liter. You still have the same mean concentration, even though you have 3 very different modes of administration. McKenna, you've got this look on your face as to say, I'm lost. The math here is just very simply, start work, please. The math is very simple. I'm going to use my mouse. So the math oh, stop, go back. See this line here? See how this is kind of an average between this trough here and that peak there? See how this line here is kind of a average between this trough here and that peak there? And see how it's kind of an average between this trough here and that peak there? That's all the math you need to know. The dosages are over here. Oh, that's the infusion rate for this. That's the rate at which you're infusing this one here. Because you're infusing it that fast, this is how fast it takes for it to get to the steady state concentration. Notice it takes 2 days. Right, 10 milligrams is your steady state concentration. That's what you'll get. And the maintenance dose is what you're trying to get to achieve that steady state concentration. And then the dosing interval is how often you take the drug at a particular dose to achieve that steady state concentration. Right. So don't think that this is the maintenance dose. No, that's the concentration you need to stay in the body to get the therapeutic effect. That's measured. The drug company knows that. They'll tell you that. Or they'll tell the physician that too. Here, Mousy, Mousy, where'd you go? There you are. So this essentially, these are your, that's your dosing interval. That's your maintenance dose. Okay, is that better? Okay, good. Caitlin, you look like you're ready to go to sleep. No? Good. You're looking down. Okay. Oh, you're writing. Okay, you look like you're kind of, I was ready to give you the, okay, taking notes. Okay. Is this clear to everybody? So when the provider tells you to administer the drug at that rate, essentially, that's what the provider is trying to achieve, is that steady state concentration that will provide the therapeutic effect. That's why he or she is telling you to do that. So steady state or average concentration in the body stays the same, regardless of the fact that you're administering the drug with 3 very different dosing intervals, 3 very different concentrations. There are equations you can use to calculate the dosing rate. I'm not going to throw this at you. I just want to show you there are ways to calculate this. These are not guessed at. They are calculated. If you know the target concentration, you know the clearance rate, you can get the dosing rate easily, essentially. And your dosing rate times the dosing interval, that gives you the maintenance dose. It's really that straightforward. And so we could do a simple sample calculation. If you're using theophylline, someone has bronchial asthma, they can't breathe. Your target concentration is 10 mg per liter in the body. Your mean clearance of this drug, very well understood, 2.8 liters per hour per 70 kilogram body weight. That essentially shows you what I was trying to get at. So, and if it's given intravenously, F, which is the bioavailability, is equal to 1, then you can just calculate the dosing rate using this equation here, and you get a dosing rate essentially of 28 mg per hour. That's where the infusion rate comes from. That's how that was calculated. And all of these numbers that I'm giving you, you can look those up. There are books essentially that have those numbers. These numbers are not hidden in some esoteric secret knowledge found in that you have to, communicate with a scar or something like that to try and get. They're published. They're all published numbers. In fact, if, 'cause Yeah, I've got a table here with some of these numbers. I've got them right here. I just copied them down from some of these books. They're not secret. And then the dosing rate will equal the infusion rate. Now, say that dude leaves the hospital. You can't say, oh, okay, here, take your bag with you. Yeah, that's not going to work. You want to give that person oral theophylline, and then you just say maintenance dose equals dosing rate divided by bioavailability times the dosing interval. How often do you want to dose the person? You want to dose them once a day? You want to dose them 3 times a day, twice a day? And that's all you do. The bioavailability for theophylline is 96%, pretty good. And you just calculate accordingly. There's your dose. And if we were to say 8-hour dose, essentially, for 24-hour dose, we could do essentially the same thing and blah, blah, blah. Now, some drugs, you want to bump them up to that steady state concentration right away. You don't want to wait for the infusion to get there. You want to get them up there because they're suffocating, say, or their heart's about ready to jump out of their chest or something like that. Then you give them something called a loading dose. The loading dose essentially gets them up there while your infusion is getting there. And so while the loading dose now starts to decrease, the maintenance dose now is coming online essentially. That's called a loading dose. And to calculate a loading dose, use a target concentration times the volume of distribution. Again, these are numbers that are all known for drugs. They're not guesses. They're very, very well understood for most drugs. And if you're giving intermittent doses, then you can use this equation here. So your strategy goes something like this. You choose your target concentration. You predict the volume of distribution and the clearance rate. There are ways to do that. You can use the published clearance rate and assume the patient will be close unless they have kidney trouble or liver trouble or something like that. And if they have kidney or liver trouble, there are ways to estimate what the clearance rate might be. You calculate the maintenance dose, and then you give it to the patient. You measure their response, and if you need to, you measure their drug concentration, and you revise based on measurements and kind of, rinse, wash, repeat, and see if it works. That's pretty much the strategy. All right, so some variables to consider when it comes to pharmacokinetics of patients. Absorption can be affected by diet. Do you remember when we talked about tetracyclines last year? Remember what you're not supposed to take with tetracyclines? Dairy, yeah, dairy, calcium supplements, any sort of laxatives or something with aluminum salts in them or magnesium salts, something like that. Those will bind the tetracycline and prevent it from being absorbed. That's an example of drugs that are affected by diet. So absorption can be affected in some cases by diet. Also, GI pathologies. Say the patient has inflammatory bowel disease. Say the patient has had bariatric surgery. Those can greatly affect absorption. And in some cases, the patient may absorb the drug really poorly, and you might have to find different formulations for patients with such conditions. Also, there are some drugs that require stomach acid to be absorbed properly. What if the patient is on proton pump inhibitors that decrease the stomach acid? Other things to consider as well. What if the drug is activated by stomach acid? The antiplatelet drug, clopidogrel, trade name Plavix, that drug is activated by stomach acid into a form that can be better absorbed. That's why you don't take clopidogrel with proton pump inhibitors. You use a different member of that group of drugs that you can take with proton pump inhibitors. And that might be important because if the patient has to take it with aspirin, they may want to take a proton pump inhibitor to save their stomach lining. Clearance. Clearance varies usually from person to person. Clearance can depend upon age, depend on level of activity, dose-dependent level of hydration. Some drugs are greatly affected. Rephrase. The clearance of some drugs are greatly affected by other drugs. For example, lithium. NSAIDs, if you take NSAIDs like aspirin, ibuprofen with lithium, that prevents lithium from being excreted. Lithium levels will now soar, and your patient's going to start to get dopey and have polyuria and get tremors, essential tremors, that they're going to become worse, and so on and so forth. And those are all signs of lithium toxicity if they take NSAIDs with lithium. Volume of distribution changes radically as you get older because you get less lean body mass. Living proof here. And because of that, your distribution, you're going to have more drugs depoting, if they're fat soluble, into fat. That's going to affect their ability of those drugs to find their way throughout the whole body. And then half-lives. Some people will have liver enzymes that either work too well or work poorly. And that's a feature of pharmacokinetics called pharmacogenetics. We'll actually get to next after we take our break, after I finish these through slides. And Bree bought a really nice dessert that, according to her dad, was really good. So half-lives can vary in people. The lesson of this, guys, is don't assume your patients are cookie cutters. They're people. They're unique, just like you. So treat them as people. If their half-life, oh, well, that's not the published half-life. Well, so what? They didn't participate in that clinical trial. Just treat them as people, okay? The half-life that are published are guidelines anyway. They're pretty good guidelines, but for some people, they may not work. Okay, what did I say? What did I do? Okay, you're having a moment. Okay, well, all right. Some people will have abnormal physiology. Some people, because they're taking other drugs, it may antagonize that drug. And then the maximum effect may differ because some people may have more receptors for a certain drug than others. This is particularly the case for those of you who will do post-op stuff with anesthetics. Some people are very sensitive to anesthetics. Others aren't. Some people, the anesthetic is removed and they wake up and they're not sick at all. Other people are asleep for an hour and they wake up and they look at the floor and they puke. And it's just, they're people. They're people. That's one example. There's lots of others too. Opioids is a good example. Some people are very sensitive to opioids. Some people aren't. And then you switch them to another opioid, and that opioid works. Yeah. To the anesthetic. There are cases of it. That happens in some cases. Some people get more immune to it. Some people, they get more sensitive to it. That's individual. Yeah. Then you use a mallet, you hit them. No. In cases like that, those are people that tend to be really resistant to pain in the first place. And you may just need to use locals, and because locals will work usually on those people. You may just need to use locals and just tell them hold really still and just strap them down and say, we're going to do it this way then. Because yeah. With that, sometimes the anesthetic you're given this, they think the surgery is going to last this long, and it lasts this long, and then they wake up, and that they need to redose you usually. Because with dental procedures, they give you the lowest concentration of anesthetic that works, but therefore it's also the dose that wears off the fastest. And you need to be redosed. And yeah, I'm sure that's terrifying, but it happens to dentists. They just, well, oral surgeons, they know to just, well, just redose you, and you're usually fine. Clearance is also something that can vary because some drugs will bind to serum proteins. And if you have some sort of liver dysfunction, you'll have less protein for the drugs to bind. Also, if they're on another drug that binds to serum proteins, those binding sites on the blood proteins might be occupied. That's another thing to consider as well. And so dosing history is also something required essentially to get your maximum value of a drug from a drug concentration measurement. And then just very simply, these can be calculated from body weight if need be. A lot of you, this won't be important, but for those of you who do peds, especially those of you who do neonatal stuff, virtually all drug administration is by kilogram body weight when it comes to a lot of peds and that. So then this sort of thing starts to become really important. So that's why I'm introducing it to you. All right. And for renal excreted drugs, if you want to know kidney levels, use creatinine clearance. Creatinine clearance is not perfect, but it's a pretty good estimate of kidney function. All right. And that's the equation. You can look that up. That's, yeah, no drama there. Okay. We are going to take a 5-minute break. Please come up and sample. Marie, what is this? Cinnamon cheesecake bars. Here, mousy. Okay, stop. All right. Okay, Brooke and Jenna, you're missing cheesecake bars. So just so you know. Okay, go ahead and come on up and have some, and we will reconvene in about 5 minutes. Okay. Yeah, I know. Okay, I found this song over the weekend. I'm a great admirer of choral music since I've sung in a lot of choirs in my day. I'm going to share this song with you guys. It will send chills down your spine. This is the Lord's Prayer in Swahili. Isn't that cool? Apparently, that is the theme song for a video game that's supposed to be released beginning of next year or something, or what have you. I don't know the name of it. I don't know the name of it, but yeah, don't know. But I was listening to a podcast and they mentioned that song, and that's a South African choir. And those two chaps who came out, who are they're supposed to be preachers of the gospel. Those two chaps are native Ugandan, so Swahili is their first language. And that just sent a chill up my spine. That's great music. Okay, I'll give you a minute and then we will start again, okay? Fix that. Okay, gang, let's get back in the saddle. Let's talk about how the liver metabolizes drugs and how variations in this can affect drug treatments used by drug treatment, drug efficacy. Also, this is the basis for many drug-drug interactions. We are exposed to lots of chemicals every day that are just foreign to our body. Just sitting right there, the carpet is full of chemicals that your body normally doesn't see in the things it eats and drinks. The paint from the walls, the ceiling is full of things that are putting things in the air. You're breathing them in right now. The seats you're sitting on, cleaners you used on these, the fabric on these, the clothes you're wearing, the detergents you use. I'm not trying to make you paranoid. I'm just trying to get you to see we're constantly bombarded every day with lots and lots and lots of foreign chemicals. These are called xenobiotics. Now, what do we do with these xenobiotics? We want to get rid of them. So the kidney does a very good job of getting rid of them. There's one problem. The kidney is very good at excreting water-soluble molecules. Many of these molecules are not that water-soluble. So what can the body do? It can chemically transform them into something that is more water-soluble. In some cases, it will detoxify them. In some cases, it will inactivate them. In other cases, it might make them worse. So some drugs, because of the first pass effect we saw, will never make it into the circulation. If they're taken orally, they go straight to the liver, and the liver is the main metabolizer of drugs. The body will chemically transform drugs using two different sets of reactions. Phase 1 and phase 2 reactions, most of the time, but not always, phase 1 reactions occur first, and phase 2 reactions occur second. There are exceptions to that rule, but that's usually what happens. There are some drugs that will pass through the body completely unchanged. We'll see plenty of examples of those. They're not the majority, but there are some drugs that do that. They just, you take them, they pass out, and they're not changed. There are some drugs that are not subject to phase 1 modifications. Instead, they go straight to phase 2 modifications, and then they're eliminated. Others go through phase 1 modification, and then they're subject to phase 2 modification. Again, phase 1 reactions usually occur first, but sometimes you get exceptions, like with isoniazid, the anti-tuberculosis drug. This is one example. In this drug, the phase 2 reaction that places an acetyl group on it occurs first. This N-acetylation now will be followed by a phase 1 reaction that hydrolyzes it. So you get this molecule here, which is pyritobenzoate. That's not so bad, but this puppy here is quite hepatotoxic. This is a reason why isoniazid, if it builds up in the body to appreciable concentrations, can cause pretty significant liver damage. There are some drugs that are prodrugs. That is, they are given in an inactive form. The liver then transforms them into an active form. This gets around the first pass effect. So omeprazole is a good example. This is a drug that's used to treat gastroesophageal reflux disease. Codeine, another good example. Hydrocodone. Okay, good.
We got you back.
Sorry, guys. Zoom looks like it kind of went a little belly up there for a bit. Let me fix that. Come on, you. There you go. Okay. When it comes to phase 1 reaction, the main players in phase 1 reactions are a family of enzymes called cytochrome P450s. Cytochrome P450s. Everybody say that with me. cytochrome P450. These are iron heme enzymes. They're found predominantly in the liver. They're also found in the small intestine, the kidney, and to a lesser degree, some other tissues. But the main place where they're found is the liver. These are complex proteins. They execute a multi-step series of reactions. And they take the drug and they derivatize it, chemically speaking. So these are going to use reductants in the form of NADPH. They're going to use it to, in a cyclical fashion, essentially give reducing equivalence to the drug that will chemically modify it. This is just an example of a crystal structure of one particular cytochrome P450. There's a molecule bound to the center here. This molecule is actually camphor, the stuff that's in Vicks Vapor Rub. That's actually bound to the center there. I show you this picture just to show you that there's a lot known about these proteins, a whole lot known. And they are associated with membranes. So they're embedded in membranes. So they're found in the smooth endoplasmic reticulum of liver cells. Many of these enzymes are inducible, not all, but many are inducible. So some drugs will actually increase the amount of the drug, of the enzyme that's in the liver cells. They're subject to extensive genetic polymorphisms. Now, what that simply means is that the genes that encode them vary from person to person. Some alleles of those genes encode proteins with lots and lots and lots of activity, far more than the usual amount. Others make alleles that have very little activity. Others make alleles that may have no activity. That's going to be significant for some of our discussions. Some of these enzymes are inhibited by some drugs. So some drugs can induce them, others can actually inhibit them. And there are over 50 different cytochrome P450 isozymes. So I have here a handout of a list of these. Please don't be intimidated by this. I just want to show you that there's a bunch of these. Yes, yes, I'll put them up there for Brooke and company. The thing I'd like you to see is that many of these enzymes specialize in certain molecules. So some of these they specialize in certain types of molecules. I want to show you just what the reactions that these tend to carry out, what they do to the drug chemically. It's going to vary. So essentially, they might essentially, if you have a molecule like this, they might essentially make it so this gets broken in half. So they might sometimes actually break molecules in half. They might also do something like this, where they add hydroxyl groups to things so they can break things in half, or just add hydroxyl groups. Hydroxyl groups are more soluble, make the molecule more soluble in water. They might also add hydroxyl groups in other places too. You might also get other things happening where things get put on and then moved and things like that. So all of these reactions make this molecule, which isn't very water soluble, more water soluble. Same song, second verse. You might also get things like oxidation. You might also have the addition of oxygen in that reaction I showed you. Molecular oxygen was a player in that. When you add oxygen to these molecules, you make them more water soluble. So you add oxygen to these things, you may sometimes break them in half. You may sometimes take carbon-nitrogen bonds and break those bonds or things like that. These are all the sorts of things that these enzymes might end up doing. All of them result in molecules that are more water soluble. That's the kind of cat's meow I want you to see about all this. There are other reactions that occur to drugs that don't depend on cytochrome P450s. So there are certain types of enzymes called flavine monooxygenases. Flavine monooxygenases. The fact that you see the word flavine means that they have a cofactor that's derived from dietary riboflavin. And these enzymes will essentially take things with nitrogen in them and convert them to things that are more water soluble. They'll do the same thing with things that have sulfur in them. They'll make them more water soluble. You also have enzymes called amine oxidases. They will take something like a primary amine and they convert it to an aldehyde. Aldehydes are more water soluble and also more reactive than primary amines. There's also a family of dehydrogenases. These take niacin-based cofactors, namely NAD, NADH, NADPH, and they will either oxidize or reduce molecules. So ethanol is oxidized to acetaldehyde. Other types of alcohols also get reduced to aldehydes that are more water soluble. You can also have reductions. So azo reductions, for example, azo reductions can break azo bonds in half to two different molecules. And then nitro groups can be reduced to amines, and the amines are more soluble usually than the nitro group. Carbonyls. Carbonyls essentially are converted to alcohols. These are more water soluble than the carbonyls. And then you have things that hydrolyze molecules. They add water across bonds. So esterases, there are esterases all over your body. They're found in blood, they're found in cells, they're found in tears, they're found in sweat, they're found inside cells, outside cells, everywhere. So esters essentially get hydrolyzed to carboxylic acids and alcohols, both of which are more soluble than the ester. Esters don't last very long in the body. This is significant because there are two groups of local anesthetics. There's the amides and there's the esters. The esters have short half-lives because those esters get hydrolyzed by these ubiquitous esterases. And then amides themselves, there's amidases. Amidases tend to work more slowly than the esterases, and there are fewer of them. So amides usually will last longer than esters. That was just a quick run through of the sorts of reactions that these enzymes will perform. Suffice it to say, these enzymes have wide variability. They have very broad specificity. And because of that, they can handle lots and lots and lots of different substrates. And I have another handout for you, talking about the different types of reactions that the liver carries out. Okay, first thing to notice about this first page here, these are iron-based proteins. What happens if you're low on iron? Your drug metabolism's not going to be very good, is it? You're going to have fewer cytochrome P450s, and your drugs are now going to have abnormally high half-lives. Think about that when you deal with adolescents, usually females with IDA, iron deficiency anemia. Something to consider. All right, so if you turn the page, please, to page 2, and you can see the summary, essentially, of some of these different enzymes and their participation in phase 1 reactions. Hydrolases, oxidoreductases, and so on and so forth. Now, some things that induce cytochrome P450s include, first of all, cigarette smoking. Cigarette smoking is a big inducer of several cytochrome P450s, in particular, cytochrome P450 1A. The 1A family is pretty robustly induced by cigarette smoke. So smokers very often will need to be dosed up for many drugs. That's something to consider. Also, eating charbroiled foods will induce cytochrome P450 1A, the 1A group. These groups here, the 2C group, they get induced by rifampin, the anti-tuberculosis drug, and by barbiturates. There are other inducers we'll look at, but those are kind of the two biggest offenders, so to speak. Then you have enzymes that inhibit cytochrome P450s. Probably the biggest culprits are the azole antifungal drugs. Azoles are notorious P450 inhibitors. So is the anti-ulcer medicine cimetidine, which is available over the counter. If someone is prone to ulcers and they're using this drug over the counter, you need to know about it, because cimetidine interacts with a lot of drugs. Macrolide antibiotics. Oh, mercy. Your prof flunked spelling. Macrolide antibiotics that would include erythromycin. Azithromycin, not so much, but definitely clarithromycin. They also are converted into metabolites that are cytochrome P450 inhibitors. Now let's talk about phase 2 reactions if there are no questions about phase 1 reactions. These reactions are catalyzed by so-called transferases. Transferases. These transferases take big, bulky, charged molecules and attach them, conjugate them to the drug or its metabolite. These big, bulky, charged molecules make the drug or its metabolite inherently more water soluble. And you have on your handout, it says conjugating enzymes. These are some of them, and they're listed here. The one that's definitely used the most are the enzymes, the UDP glucuronylyl transferases. These UDP glucuronylyl transferases, they attach gluconic acid residues to drugs. Gluconic acid is big, bulky, charged, and extremely water soluble. Others will transfer methyl groups. Methyl group transfers, particularly to nitrogens, make the nitrogen charged sometimes, making it more water soluble. Sulfate, sulfotransferases will transfer sulfate groups. Sulfates, big, bulky, charged. Glutathione conjugation, glutathione is a 3 amino acid peptide. That 3 amino acid peptide, when transferred to drugs, now makes it big, bulky, charged, and very water soluble. And then glycine and acetate gets transferred to some drugs, again, making them much more water soluble. And this just is to show you essentially the types of places where you would attach a gluconic acid. That's gluconic acid. You can see it's derived from glucose. And you'll attach it to lots of different places. You'll attach it, you know, there, you know, so on and so forth. This gets attached to lots of different drugs and drug metabolites and makes them very water soluble. Let's talk a little bit about some of the genetic variations in cytochrome P450s. Let's talk first about cytochrome P450 2D6. 2D6. 2D6 is pretty important for certain families of drugs. 2D6 is the drug that activates many of your opiate prodrugs. It's also a drug that metabolizes several antidepressants. Some people are naturally deficient in cytochrome P450 2D6. The degree to which people are deficient for this particular enzyme is going to vary between different populations. So for example, in Caucasian populations, about 10% of all Caucasians don't have any 2D6 activity. None. Zero, zip, nil, nada. 2D6 substrates would include things like most antidepressants, a big slew of antipsychotics, beta blockers, which are used for blood pressure regulation, morphine analgesics, and then assorted other drugs. People deficient in 2D6 activity are very slow metabolizers of psychopharmaceuticals. They're also very slow metabolizers of beta blockers. And if you treat them with opiates that are prodrugs, they will get no pain relief from those drugs. So if they're slow metabolizers of these drugs and you're dosing them normally, normal doses of those drugs are going to be toxic to them. In contrast, many persons of Ethiopian and Saudi Arabian origin have duplications of the gene for cytochrome P450 2D6. So they have huge amounts of this enzyme. They're called ultra-rapid metabolizers. So a third of all Egyptian and Somali descended people are super high metabolizers. These people will need higher doses of antidepressants, antipsychotics, and beta blockers. However, if you treat them with normal levels of, say, codeine, they'll suffer from morphine poisoning because it's turned into morphine so fast. So that's an example of one enzyme where people can show pretty substantial differences in metabolism. Let's talk now about this one at the bottom, 2C9. There are people with 2C9 that have decreased 2C9 activity. These individuals cannot tolerate normal doses of the anticoagulant warfarin. They'll be at high risk of bleeding if you put them on warfarin because they don't metabolize it. And they'll have adverse effects with other types of drugs too that are metabolized by 2C9. (2C19) is the principal enzyme involved in the metabolism of several drugs that are used to treat malaria, several oral anticoagulants, proton pump inhibitors, anti-cancer drugs, and antivirals as well. There are several allelic combinations of the gene that encodes this enzyme where folks have no activity whatsoever. In Caucasians, it's about 15% of the population. 21% of the Caucasians, however, have increased activity of 2C19. And these individuals will chew up drugs really fast so that normal dosages of these drugs won't work. Those are just a few examples of drugs whose metabolism is affected by genetics. We'll talk more about this in our genetics class. Suffice it to say, there are commercially available genetic tests for the various alleles of these enzymes. So if a patient's not responding or if they're hyper-responding to an enzyme, to a drug, excuse me, you can actually have them tested. Insurance might not pay for it, but they are available commercially. Other factors that will induce differences are, of course, smokers. The other biggie is grapefruit juice. Grapefruit juice has complex carbohydrates that inhibit a particular cytochrome P450 that's used extensively, cytochrome P453A4. Because it inhibits 3A4, and 3A4 is so widely used by lots of drugs, if you go to retirement homes, they will say no grapefruit juice is allowed in this facility. Milk thistle. Milk thistle is used as an herbal remedy. It inhibits phase 2 reactions. So milk thistle can actually prevent the proper metabolism of certain drugs. St. John's wort is taken by some people for mood stabilization. St. John's wort is a notorious drug interactor. St. John's wort is a potent inducer of several cytochrome P450s. And if someone is taking St. John wort and the drugs you're giving them doesn't work, that's why. St. John's wort turns the liver into hyperdrive. All right, I'm going to stop right there. We're going to then pick this up on Wednesday. Don't forget, we have a quiz on Wednesday. I want to give you this handout because these are case studies of examples. They're very short little case studies. What I'm going to do is please bring this Wednesday. I'm going to split you up into little groups and have you figure these out. So if you read up on them before you come to class. And those of you on Zoom, or might be on Zoom, I'll assign you maybe just to a breakout room or something of your own.
Are you gonna allow us to like questions?
Yes. Yeah. Four.
Is this on Blackboard?
It'll be on Blackboard by tonight. I'll put it on Blackboard.
Is there? I have the one from
Yeah, yeah, because the weather is going to be nasty. Clara takes back roads. There's a good chance she won't be here. Maddie may not either, because she's in Jackson. Those back roads aren't plowed. And some of them get really, really built up. I had a student once, she's from Wisconsin. She was in Grand Rapids, the roads there are crowned really extensively. She came up to a stop sign, she stopped, and then literally her car just went right into the ditch.
I don't know if you got by Jackson College over there.
Yeah, yeah.
Yeah, I had to pull the e-brake on my car. Until we stop it. Like if a car would have been coming, I would have been.
The cop came by, and if you get in an accident, the cop gives you a ticket. He wrote her up. He said you were speeding. She said I was stopped. He said, well, you're obviously speeding because you're in the ditch. She said, I stopped at the stop sign and the car slid into the ditch. I was stopped. So she wouldn't sign the ticket because it said you were speeding. And said, I wasn't speeding. I was stopped. I can't sign this. I'd be lying.
Yep.
So he wrote something else on it or something like that, and then she signed it. And she went to court and she contested it, and the judge laughed and said, "Oh, you're kidding." Climbed the gavel, said, "Get out of here." Dismissed it.
Is it quiz on Wednesday 5 questions or how many questions?
Five. There's big space up there. You look like a spade.
Mushroom, I think
Yeah,
it's like.
mushroom. Okay, I'm thinking a spade. Usually it's a shovel.
Is the quiz gonna be the API based?
No, this will be paper, but since some of you won't be here, maybe I'll put it on Blackboard for you guys.
Okay, is it based on the API stuff? or
No,
the
it's based
main
on
book?
what's said in class.
Okay. No, sorry. I can, usually what we do is like, we try to write the questions for the quizzes for the mathematics. And so if you do it on Facebook, you can always try to send you a picture over text or something. Questions that you might want.
Yeah, yeah. They tend to write pretty good questions. So I'm very proud of this group there. My babies are growing up writing good test questions. Yeah. So yeah, no, that's when you guys started out, it's pretty rough at first, but you guys got better. You got better at it. You think you learned how to write questions because I didn't have to tweak them very much after a while, which was quite gratifying. So yeah. So I'll probably maybe do something more Blackboard based for you all. No, because I want to see how behind I get. The one quiz I put together this weekend, it's practice, it's not proctored. The test, if you do a test on ATI, it has to be proctored. I just got my proctor recertification done, so I can proctor now. So you guys would have to essentially be on, be either in class or online and do it that way. I'd prefer to do it online if we do that. But what I have up now is a practice test to show you what kind of questions they would ask. Did you see it on ATI?
I don't know. I did the unit and everything, and then I did the questions after.
Because I made it available. Let's have a quick gander here.
So should I
Okay.
really study all the P450, all that stuff too? Because I just assumed that it would be mostly API based, and because I